Well, thank you everybody for being here this afternoon, this evening, whatever time zone you're in. My name is Megan Hansen. If you have joined some of these before, this will be old news to you. If this is the first time you've joined an RPLA event or one of our Ask the Expert conversations, I'll just give you a quick introduction. So I am the co-founder and executive director of Recurrent Pregnancy Loss Association, or RPLA. RPLA is a nonprofit organization. We're completely volunteer-led, and our mission is to eliminate recurrent pregnancy loss. And we do that by trying to enable research, advance our understanding of what causes RPL, how it can be prevented. And then we also do a lot of educational events like these, community support type of events, and advocacy work. So this Ask the Expert session and our series of these videos, the intent of these is to give us a time as patients. I am not a medical professional. I am not a mental health care professional. I am just someone who lived through this. It's an opportunity to ask questions of expert care providers from a patient level, not an academic level. So I am really excited to be here today with one of our board members and a friend of mine, Dr. Michaela Stevenson Wyszewianski. And I practice it all the time, Michaela, and I just
You did
want to
great.
say it
Perfect.
again. Yeah, Wyszewianski. There, that one rolled off easier. So Dr. Wyszewianski is a resident physician in obstetrics and gynecology at the Medical College of Wisconsin, and she is a rising reproductive endocrinology and infertility fellow at UNC Fertility, at University of North Carolina. Sorry, for those of you that don't know UNC. She has a strong research interest in recurrent pregnancy loss, and she's engaged in multiple research projects on recurrent pregnancy loss. She had a number of presentations at last year's ASRM conference. She has been on our board for a year. This is her second year on our board. And in addition to her medical training, she brought a lot of experience in nonprofit work and political and community organizing. So, and she's very passionate about patient and provider, but patient education. So I'm really looking forward to this topic today, talking about thyroid health. It is Thyroid Health Awareness Month, so it's the perfect time to have this conversation. And Michaela, I'll let you do any additional introduction that you want, and then we can get into questions.
Yeah, for sure. I think the biggest thing that people should know right off the bat is that this is not medical information. So if anything sparks up that you're like, that could be me, I cannot provide you with a specific consultation or anything like that. But I would encourage you to reach out to your, you can be a primary care provider, it can be your OBGYN. A lot of the things that we'll talk about here are things that are totally appropriate for OBGYNs or PCPs to address. A lot of the times, if something is too difficult or very nuanced for those physicians to address, they'll refer you to an endocrinologist. And the other thing is that these are my views, these are my opinions. They don't represent the views or opinions of the Medical College of Wisconsin or the University of North Carolina.
Yeah, thank you. Fair point. And thank you for all of those disclaimers. So, and thank you for everybody. Hopefully I did get some people interested in sending questions. So I think we'll hopefully get those answered during this. But let's start with basic overview of what is the thyroid and what does it do and why should we care about it at all?
Yeah, so we're going back to medical school first year where
Yeah.
I spent a lot of time talking about every organ in the body. So your thyroid does a lot of different things. So your thyroid basically regulates many different processes in the body. Your thyroid is responsible for helping you metabolize calories appropriately. It's responsible for heat regulation. It's responsible for helping to regulate the menstrual cycle in some ways too. And a lot of what we know about what the thyroid does is actually what we know from when the thyroid isn't working very well. It plays a role in maintaining pregnancy. It plays a role in continuing to grow a healthy pregnancy as well. So many, many different things. The thyroid by itself doesn't really do anything. You need your pituitary to work well. You need your hypothalamus to work well. So brain structures higher up are responsible for regulating the thyroid.
And Taylor, I see your question. I've got that. And I think it's a really good question. We can come back to that. I think it'll come up in our conversation, but thank you for asking that. So what Okay, if my thyroid was not, if there was some abnormal dysfunction of my thyroid, what might be some of the signs and symptoms that might be presenting with? Or could there be something wrong with my thyroid and I'm completely asymptomatic? Like, how would I know that this is an area to explore?
Yeah, so a mentor of mine actually brought up the fact that people who have thyroid problems may not actually know that they have thyroid problems because at some point your body doesn't just keep being out of whack. You start to get used to the fact that you're just not functioning as well as you once did or the way that you could. So your thyroid often the biggest thing that people complain about is hypothyroidism, really, where the thyroid is just not functioning enough. You're not producing enough hormone. And so because of the way that many endocrine or like hormone systems works in the body, what you'll find is that your thyroid stimulating hormone or your TSH is elevated because it's basically your thyroid trying to say we need to produce more thyroid hormone and we're not producing enough thyroid hormone. Let's send more signals. Let's hammer page. Let's call this thyroid hormone up a bunch of time and see what happens. So oftentimes, when a person has hypothyroidism, their thyroid levels will be high, their TSH will be high, but their actual thyroid hormone will be low. Um, and so signs of that are often fatigue. It can be heavy bleeding or abnormal periods. People present differently. Um, a lot of it is like just tiredness, like very, very tiredness, having wasting of the muscles. There is something that can happen where people have profound hypothyroidism and they can actually go into a coma. Most people don't present that way. That's not something that we find out. In older people, sometimes there is a level of dementia that can happen, but decreased ability to function, having like just like having like cold, clammy skin is something that can also happen. But a lot of people have fatigue. Honestly, a lot of people may not even know that they have hypothyroidism because they're like, I just feel tired and I'm cold and I thought I was just anemic and it's fine. I'll take some extra iron pills and then it doesn't work. And then they kind of come in for further evaluation.
Okay, interesting. Um, I know I'm thinking that makes so much sense to me, and I've never thought of it that way. It's like if something doesn't happen uh, dramatically, if it's a gradual change, you do just get used to your body, and it's like homeostatic state. And so, yeah, you wouldn't be. You're like, am I tired? Am I more tired than other people? How am I supposed to know if I'm more tired than other people? That
Exactly.
is a really good point. Um, so how how would those things, or how does that thyroid health then influence fertility and like pregnancy health? What is the interplay between well-functioning thyroid or a dysfunctioning thyroid and healthy pregnancy?
Yeah, so a lot of it is actually that it depends on your kind of thyroid dysfunction. The thyroid can work too well, and you can have something called hyperthyroidism, where your thyroid is trying to calm things down because there's too much thyroid hormone pumping out. It's not trying to call up those additional thyroid hormone, but there's still more thyroid hormone that's coming into play. What often happens with hypothyroidism is that's where we see a lot of miscarriages happening. That we they're not producing enough thyroid hormone. That thyroid hormone gets regulated with medications, things are better, and then as a result of that, people are able to carry pregnancies. What happens sometimes with other people is they may not miscarry, but they may have an infant that develops abnormally in utero because you need thyroid hormone to kind of help regulate the development of the brain in fetuses. And so even if you don't have any concern for like an infectious process or an autoimmune process that's actually causing you to have issues with your thyroid, though there can still be issues with fetal development because there's not actually enough hormone around to like help develop the baby's brain. And so old school language that says that people might hear is called cretinism, where the baby has these particular faces, but also the baby ends up having neurological abnormalities that they don't see until later in life, into like, early on, like 1 or 2 years. Um, Hyperthyroidism, you tend to see that less, but the baby can also have hypothyroidism from having hyperthyroidism just because there's too much signal, and the baby interacting with the mom's endocrine system can end up trying to regulate itself and then regulate kind of inappropriately. You do see patients who have hyperthyroidism that gets corrected with medications, and then they do go on to have healthy pregnancies. The same thing with hypothyroidism, that people may have early miscarriages after things are corrected with thyroid hormone that's supplemented, then they go on to have pregnancies that aren't influenced by these complications.
So if they and if If you had, if thyroid dysfunction was the potential contributing cause of recurrent pregnancy loss, are those losses going to be typically manifested as like early losses, or are you going to see the impact or the like that later in a pregnancy?
It's typically a first trimester loss, so
Okay.
typically pretty early on in the process. Thyroid is so important to the development of the fetus that if you don't have enough hormone around, it's usually that you're going to have a baby with some issues pretty early on. Same thing with hyperthyroidism, usually because the endocrine system is so sensitive in a fetus, it's going to just not work out the way that we would like it to, and it's usually going to be earlier losses. Later losses, especially after 20 weeks, is usually something very different going on. So I wouldn't want anyone to walk away from thinking like, oh, if somebody had just checked my thyroid, I wouldn't have had that 34-week loss. That's super heartbreaking. It's probably not associated with your thyroid though.
Yeah, no, thank you. That's helpful context. Anthony, I see your question about thyroid disease and men. Just to kind of level set, this conversation is not going to be specifically talking about thyroid health and men's health. Although I don't know, that wasn't a question that we had on the list, so you don't have to answer it, but is there a relationship between like thyroid health and potential sperm health? I don't know.
Gosh, I do not know. I am
Yeah,
an OBGYN.
yeah.
I will
So,
look into it though.
yeah.
I will try to find some information in the next couple of days, and I'll try to send something back to Megan to see if we can post that.
Yeah, no, that's a great question, though. Thank you for asking it, Anthony, and thank you for being here. Okay, to move, like going then from, you mentioned like what some of the symptoms would be, and you said that what might show up in labs is that like your TSH would be high, but your thyroid levels would be low. Can you talk more about what is like sort of the standard first tests that are done? Like what specifically are those tests, and how do you know if they're normal or abnormal?
Yeah, so like most things in medicine, there is a range of normal, and what the current guidelines for the American Society for Family Medicine, for ACOG guidelines, what they tell us is that typically for a person who's coming in who could be pregnant or is pregnant, that we should have regional levels of normal for thyroid hormone. Now we don't have those. We certainly don't have those where I'm located. So typically that's going to be about 0.5 to 4.5, and then that goes down when you're pregnant. The thyroid always is a little bit more active during pregnancy, and so your thyroid doesn't have. We don't expect the thyroid to call on as much to produce thyroid hormone for us. If it's lower than that, that can be a sign of hyperthyroidism, but you have to kind of think about the whole context. If it's higher than that, that can be a sign of hypothyroidism, where that thyroid is not working as well. The next test after I do the TSH is looking at the actual level of the thyroid, because your thyroid level, your thyroid hormone level could be low or high, and your thyroid hormone could be normal. And so if you fall into that category of normal, you either have subclinical hyperthyroidism or subclinical hypothyroidism. And subclinical means you usually don't have any symptoms, or we
Mhm.
think your symptoms are not related to this thyroid condition, and that your thyroid hormone level has to be normal. And so in the setting that that happens, we should not keep hunting. It's time to stop. We should say you have a subclinical disease. We don't need to keep looking, especially if it's in like the norm, if it's not too high or too low. We just stop. We say that we don't have anything. Treating subclinical hypo or hypothyroidism, hyper or hypothyroidism doesn't improve your pregnancy outcomes. It doesn't increase your risk of having like dementia or thyroid storm or any other complications associated with thyroid conditions. And so we should just stop. I have seen people think that that we need to go ahead and treat this. You don't. It doesn't improve your outcomes. Any potential risks associated with treatment of these, we're giving you risks without any benefit. There's probably limited risk to treating hypothyroidism with levothyroxine, which is thyroid hormone, but medications for treating hyperthyroidism like methimazole or PTU do have risks associated with them, especially if we're exposing a baby inappropriately in utero. That does have some risks, and so we wouldn't want to treat something, especially if the medications are slightly risky.
Okay, let me replay that back because I think that was all really important information. I want to make sure that I understood it and that everybody else got that too. So, because I'm not sure, so this is a good test. So, what you're saying is like in the context of subclinical hypothyroidism or subclinical hyperthyroidism. Your TSH is going to be normal, but your thyroid hormone might be either a little high or a little low. However, there's not necessarily a benefit of treating in that case because your outcomes aren't going to necessarily improve, and there might actually be some risks in some cases to the developing fetus. Did I get
Very
that right?
close. The
Okay.
TSH is either elevated or lower, but the thyroid hormone is normal.
The thyroid hormone is normal. I see.
Yes.
I see. So your TSH is slightly out of range, but your thyroid hormone is actually in range.
Yep.
Ah, okay. Yes, I did misunderstand that. Okay. That's interesting. And so treating in that case, it isn't helpful because your thyroid's actually in normal range.
hmm
Okay.
Like your thyroid is it's doing what it needs to be doing. There are people who, at some point probably do transition into having like true, we call it overt clinical hypothyroidism or hyperthyroidism, where you do actually have a thyroid problem. You can often just monitor somebody with subclinical disease. You do another test in several months or a year and see if they have converted over.
Okay. How you talked about like normal ranges and sort of that like reference range for normal. Is that how do those ranges work? Is there like a different range for my general, I'm just going about living my life? Is there like a different optimal range if you're trying to conceive, or is that the same?
Yeah,
Because
I
I
think that's like,
particularly with RPL, I've seen this like, is it normal or is it 2.4? Is it less than? So like, walk us through that piece of it.
yeah, so there was
Yeah.
a huge shift a couple of years ago. Even like when I was in medical school, it was pretty common, and like a lot of older, having practiced for a while, physicians were using like that number of 2.5. Like everybody was like, it should be 2.5. In some of our older textbooks, they're like it should be 2.5. If it's above that, it doesn't matter. You should go ahead and treat this because of all of the studies came out that said it didn't matter. And so you can use the range of normal in your community or the regular range of normal. And if you use that range of normal, that's fine. Everybody has different, goals, and like the American Endocrine Society is going to have a different opinion, and the American Society of Reproductive Medicine is going to have a different opinion, and ACOG is going to have their opinion. American Society of Family Medicine is going to have a different opinion. Everybody has a different opinion. What I have been able to glean from looking at most guidelines is that currently screening for thyroid conditions in people who don't have any history of anything concerning for thyroid conditions, so never had a loss, not having any symptoms, and you're just pregnant, we don't need to screen you for thyroid problems. You're probably not going to have a baby that has any developmental issues due to a thyroid problem if you don't have any symptoms or signs. Um, and we can use the normal reference range. You can drop it by a little bit for pregnant women because we know that thyroid is gonna, your thyroid's gonna try to produce more. So you can usually drop it by about 0.5 if they're pregnant. But for everybody else, even if they're trying to conceive, you go ahead and you use the normal range.
Okay. If you do have a history of loss or you have, I don't know, history of thyroid issues in your family, um,
Mhm.
but you haven't had a loss, like, is this something that should be screened for preconception, or how early in pregnancy or when you're trying to achieve pregnancy should you have your levels checked, and how frequently, like how fluctuating are these? How
Yes.
closely should it be monitored?
Yeah, for sure. So I think somebody who has a really strong family history of thyroid conditions, like my mom and my sister and everybody in my family has thyroid conditions, that's probably somebody that I would screen in my clinical practice. Somebody who has had difficulty conceiving, like, it's been a year or two that they've been trying to become pregnant and they're having abnormal periods, I'd probably also screen them. If it's a very short cycle or very long cycles, so that's somebody who I would screen because we know that people who have hypothyroidism can have some abnormal uterine bleeding. But other than that, if somebody's like really tired and they've got dry skin and they've got some swelling in their legs, or it's something called lid lag that can happen where somebody's eyelid is like pulled up. That can be a sign they have like what looks like enlarged eyes. That can be a sign of hyperthyroidism, especially like the old thing is that you compare their old driver's license to what they look like now. And if their eyes haven't looked like that and it's like a recent development, that can be concerning for like a new thyroid condition. And so for somebody who has like, the classic face presentation of hyperthyroidism, or they're having hot flashes and their periods are abnormal and they're really sweaty all the time, that's someone I would screen. I wouldn't screen anybody who is just kind of just coming in and doesn't have any risk factors at all. Um, But that's where our detailed history comes in. And so if you're like, well, my periods are abnormal and I'm having some issues with fertility, I'd probably go ahead and screen that person. But just your run of the mill person who's like, I'm concerned about my thyroid, I'd probably ask them some more questions to figure out why.
Okay. Um, Another thing that I see come up, and this is like sort of related to that subclinical and like what should the level be, and if your thyroid's normal but your THS. The other thing that comes up a lot in like chats and in the conversations around recurrent pregnancy loss is the thyroid antibodies
Mm.
and kind of autoimmune thyroid related conditions. So, can you talk a little bit about what that is and who you're looking at to screen for that? Is that something that anybody who has sort of unexplained recurrent pregnancy loss, that's a consideration? Or like walk us through that piece of it.
Yeah, for sure. So a lot of people, I think that the big thing is that a lot of people who have normal thyroid hormones are gonna have antibodies. There's like I think a 1 in 5 chance that like I have no history of recurrent pregnancy loss and I could have thyroid antibodies. I don't have a thyroid problem though. And so you don't routinely screen for that. What you do is you look for thyroid antibodies if somebody has an abnormal thyroid test and their thyroid if their TSH is abnormal and their thyroid hormone, their T4 is also abnormal. Um, and so that's when you go hunting. And it's because thyroid antibodies themselves don't necessarily mean that a person is going to have any other problems or that they're even related. There can be all kinds of reasons why people have antibodies to anything. And so going down that path kind of boxes you into a corner medical legally about why didn't you treat this. You don't look for things that you don't want to know the answers to that don't necessarily matter. And so if somebody is having losses, I would start with their TSH and their T4. If those were abnormal, then I would go look for antibodies.
Okay. So, yeah, that makes sense. So, like TSH is abnormal, but T4 is normal. You're kind of stopping there.
Mhm.
TSH is abnormal. T4 is abnormal. I'm going to take a deeper analysis here of
Yes.
what's going on. Okay. And so is that if then, in that scenario, THS is abnormal, T4 is abnormal, you found the presence of antithyroid antibodies. What does that mean clinically, and how is it handled then as a next step?
So it's very helpful to find out that somebody has antibodies because then you can establish a diagnosis. Most people who have hypothyroidism are going to have Hashimoto's thyroiditis, and that's very easily treatable. You give them levothyroxine, they get better. There can be antibodies also with hyperthyroidism. We still treat it the same way. The antibodies just kind of help us tell where it came from.
Okay.
There can also be other reasons why people have hypothyroidism. People can have thyroid destruction from surgery. Like, somebody can have part of their thyroid removed. I had my best friend in college had her thyroid removed because she had thyroid cancer. That can be like another reason. Also, people can have something called postpartum thyroiditis, where they just have it like they're not producing any thyroid hormone for a variety of reasons. It's related to recent pregnancy. And so what I would say is that um, you you're looking for this to help you establish a diagnosis. The next question that people ask is, do those antibodies pass into the baby's bloodstream? And they do. And so there are times when you have somebody who you're treating for hypo or hyperthyroidism and they're pregnant. They want to know what does this mean for the rest for my family member? What does this mean for my baby? It means we need to tell the NICU that we're treating them. And the NICU needs to come and they need to evaluate the baby. The pediatrician needs to know about maternal history. They need to know that mom has this history. It usually doesn't mean anything, but we can see that until the baby's own thyroid after birth kind of picks up and starts producing appropriately, that the baby can have some signs of hypo or hyperthyroidism that require treatment.
Got it. Oh, that's really important to know. That's really important to know. So, and then in terms of, I mean, if you're treated during pregnancy for an autoimmune thyroid related condition, or even just a thyroid condition in general, if you're taking treatment during pregnancy, um, is that, again, going back to kind of levels and medication management, is that something that is like dynamic over the course of the pregnancy? Are you needing to look at it regularly, or how, how closely and how worried should people be about monitoring that piece of their ongoing pregnancy?
Yeah, I think that's really important. So people who come into pregnancy with thyroid conditions need to be screened regularly, because if what ends up happening is that you probably need more thyroid, you need more thyroid hormone throughout pregnancy than you needed before you became pregnant. That's for protecting mom, that's for protecting baby. And so what is recommended by the American College of Obstetricians and Gynecologists, is that it's checked at least every 4 weeks while you're trying to increase their amount of levothyroxine. If they were getting thyroid hormone treatment because they had hypothyroidism, you're usually just giving them one extra dose a week. And so they take two, if you were on 25 or 50, you take 100 one day, and then you keep it the same the rest of the day, as long as they're appropriately responding. To treatment based on what their thyroid hormone is. When you're not treating them, or when you're not changing anything, it should be checked at least once a month. Some people usually check once a trimester if it's been pretty stable. I would say that because of like endocrinology recommendations and family medicine recommendations, I would say my practice is typically to check once a month and recommend it's a blood test, so it's not very invasive, is to check once a month. And it's because if you miss something, it can become a really big deal. But checking once a month or once a trimester is pretty standard.
Okay. And then to go back to Taylor's question that came up at the beginning, like if you're going into a pregnancy with a known thyroid condition and you're being treated for it, who then is the kind of central point of care for that? Does that switch over to your OB? Is it still your endocrinologist if you're working with one, or your family doctor if you're working with one? Like, who should be the one that's like responsible for monitoring that and making any type of medication change orders?
Yeah, I think it highly depends on what diagnosis it was. So if it's hypothyroidism is very easy to take care of. It's not at all difficult. There are very few nuances in managing hypothyroidism. So if you have hypothyroidism, your OB diagnosed it, and they feel comfortable continuing to treat you, you can see that person. If your family medicine physician diagnosed you and they feel comfortable treating you, they can continue treating you. It gets a little bit hairy with hyperthyroidism. There are important medication changes that need to happen and important nuances to those medication changes. What I've seen in my clinical practice is that most people with hyperthyroidism are referred to an endocrinologist, and the endocrinologist manages that. There are people with hypothyroidism who are managed by an endocrinologist. And so I think if you had an endocrinologist who is seeing you and taking care of you, you should stick with that person, and they're going to understand that pregnancy is different, that levels are different. There are very clear guidelines about how to manage it in pregnancy. So they're usually going to manage in consultation with your OBGYN. Some people will see a maternal fetal medicine doctor for it. They don't necessarily need to, but some people will do that. They're going to be good at managing that too for you. And sometimes they'll call upon endocrinologists to help them as well.
Okay. Thank you. Um, so let's start talking about some of the, like, I don't know, gray areas, right? You kind of mentioned like that the thresholds have changed. Why, can you talk a little bit more about like why there is still disagreement here, and how then, if people have, seen multiple doctors that have different opinions, how should they as patients be managing or thinking about that, right? It's not on the patient to manage it, but how should the patients be kind of thinking about making the right choice for they themselves? What information can you give us to kind of alleviate that anxiety burden?
Yeah, I actually spent a lot of time thinking about this like pretty recently about like, me and somebody else were kind of disagreeing about whether or not this person had this diagnosis. And I was inheriting this patient, so I was trying to decide what I was going to do, knowing that this patient had gotten this diagnosis. And so for hyperthyroidism, it's different. You have to be very critical about it because those medications can have some level of danger to them, right? And so for hyperthyroidism, if somebody's got hyperthyroidism, they're going to go see an endocrinologist. Our endocrinologist is going to manage them. And I'm probably going to be talking to that person. For hypothyroidism, levothyroxine is benign. You're probably not going to give yourself too much you're probably not going to give yourself too much thyroid hormone. There are people who do accidentally, get like a hyperthyroid state because they're giving themselves too much thyroid hormone. But the way that I think about this, and the way I thought about this for this particular patient, is if I am wrong, I'm exposing her baby to bad things, to, you know, having developmental abnormalities, to having all kinds of problems. However, if somebody is hearing, you know, 2.5 from one person and 4 from another person, I think the best way to navigate that is to ask those people to talk to each other. If your endocrinologist disagrees with your OBGYN, they need to have a conversation. If your family medicine doctor disagrees with your OBGYN, they need to have a conversation. Because I think we all have the patient's best interest in mind, but we sometimes take different paths to get there. And so I think the best thing for a patient to do is to just say, like, have you guys had a discussion? Can we do a care conference where you guys are actually talking to me, or at least to each other, about how you're going to take care of my care? It is not at all uncommon for people to have care conferences at all, especially for complex patients. And physicians and other healthcare providers should be very used to talking with other healthcare providers regarding, you know, differences in opinion regarding recommendations. So I think asking them, like, hey, can you have a conversation with this person because I'm hearing two different things, is very reasonable. I know that if my patient asked me, like, hey, can you call up my endocrinologist and see if you guys can just talk to each other, I'd be more than happy to just make that phone call, because it's very easy to do, to just call and ask for clarity. And sometimes all it is saying, you know what, our society recommends this. Can we look at these guidelines together and see if maybe your guidelines also say that? Oftentimes, what it is that one person is less informed than the other person. And so all you need to do is have an opportunity for some education there, and asking for some clarity as a patient, saying, like, can you guys talk to each other, can be very meaningful. I know that whenever a patient has told me, like, hey, can you talk to this person, I've always like called up that other doctor and had a conversation.
Yeah, that's really good advice. I actually had to do that with I was working with I mean, this is not about me, but I was working with a reproductive endocrinologist and a reproductive immunologist, and they very much disagreed. And so I asked them to get on the phone and talk about it. And you know, at the end of the day, it was just because what I'll say from like a patient side of things, right? Like the danger that we can get into is like, oh, we don't want to disappoint our doctor. We don't want to like be the kid that like misbehaved. And so if you're not telling your doctor that you're doing something or that you're not doing something, that can impact your care. And so at the end of the
Yes.
day, I think that transparency between your care teams is so important.
Yes.
Yeah.
Please tell your doctor if you're not taking your medications. It's okay.
Yeah.
We just want to know. Like, it's all right. We just want to know.
What outside of medication, or is levothyroxine? I mean, for I think with recurrent pregnancy loss, I think we hear more frequently about hypothyroidism. Is levothyroxine the only course of treatment? Are there different courses of treatment, or are there other things that we can be thinking about holistically to support thyroid health in the context of RPL and pregnancy?
Yeah, I love that question because I think a lot of people, for a variety of reasons, just have aversions to medications. Unfortunately, there is nothing else evidence-based that you can actually do. For hyperthyroidism, I would definitely recommend that people take medication. Like, that can be a really bad situation. For hypothyroidism, I would also recommend that people take medications. And the reason is because you probably can go for years without noticing that you have hypothyroidism. And then all of a sudden you can end up in a really bad situation where you're in a coma. And so it's a pretty, levothyroxine's a pretty benign medication. It doesn't really make you feel that bad. So I would say there's probably not any like holistic things that you can actually do to get your thyroid working a little bit better. Unfortunately, you know, exercise and diet don't necessarily contribute to improving your thyroid, and that you just kind of have to take the medication. The reason I feel comfortable saying that is because levothyroxine is like a generic thing. It costs like 12 cents. And so it's cheap, it's easy, it's, you know, something that you, if you're diagnosed with hypothyroidism, may be on for the rest of your life.
How quickly does it work? How quickly would somebody see the benefits of getting on treatment?
You probably are going to like physically see the benefits a little bit earlier, but we know reliably that the hormone levels are going to respond at like 4 to 6 weeks.
Okay.
And so they should see, if you don't see anything by 4 to 6 weeks and you're not feeling any different, the likelihood of one, it not being your thyroid, that's pretty low, but that could be what it is. There are people who it's not actually their thyroid, it's a higher up brain thing that's going on, but we don't typically see that. That's very abnormal. But they should see clinical improvement within a few weeks. If they're not seeing clinical improvement within a few weeks, it's usually because the dose is too low. And so we'll increase the dose again and then reevaluate symptoms.
Okay. And then I've seen with levothyroxine, I've seen things about like it matters when you take it or how you take it. Can you talk at all about like the administration and how is that something that people need to be thinking about if they're on medication for that?
Yeah, empty stomach. So, levothyroxine can bind with calcium. And so a lot of people will like wake up and they'll drink coffee, but there's milk in their coffee, or they'll eat yogurt or something for breakfast. So it needs to be on an empty stomach first thing in the morning, and about an hour afterwards you can eat.
Okay. No, thank you. Um, so let's shift. I have some other questions about like long-term health and so and related to like, and I know you've done research here too, but kind of like long-term implications of thyroid related issues that were causing recurrent pregnancy loss. What do people need to be thinking about in terms of their long-term health and managing this piece?
I think that the biggest thing that like for many years, thyroid, like most things, thyroid conditions can go untreated for many years, and then people may not notice that they're going untreated. So there are people who go off their thyroid hormone, they feel kind of crummy, but they kind of get used to it and they're okay. The problem is that the thyroid will progressively attempt to uh to work and not work very well. And so in that progression of attempting to work, it may work themselves in to it's called thyrotoxicosis if it's hyperthyroidism, where it's just like you've got too much thyroid hormone going around, you're getting heart palpitations, you're not feeling well at all. That's going to make you not just feel bad, it's going to be damage to your heart long term, for failing to correct the issue. And for hypothyroidism, it's just that you're not getting that thyroid hormone. You're gaining weight. You're getting metabolic syndrome because you're not necessarily correcting your hormones, and your metabolism are not working the way that they're supposed to work. You're dry, you're sweaty, you're tired, you don't feel good, but also that can cause a coma. It doesn't usually, but it can.
Yeah.
And so I think, you pretty much take yourself out of the pool of people who can get any of these things if you take your thyroid medications. Treated, it shouldn't cause any problems.
Okay. Um, I had a question as you were talking, and now I've completely lost it. Oh, you were saying that, if you've got like, if you had sort of a lurking thyroid issue and then it kind of starts to manifest over time, is that something that people need to then be thinking about over the trajectory of their like family building years? So if I
Yes.
had a successful pregnancy when I was 25 and now I'm struggling and I didn't have any thyroid issues then, but now I'm struggling, like how should I be thinking about like age related components of this? Yeah.
Yeah, so people can develop thyroid conditions at different points in life. And so it's not something that you're born with, it's something that you can be predisposed to, but you can just for whatever reason develop like, it's very possible that I'll turn 50 and I'll have a thyroid problem. And so if somebody didn't have a problem becoming pregnant and then they started having losses, I would certainly say like, did you develop a thyroid problem? And that's what this is. Especially if they had like, other concerning symptoms, or if they were just having trouble getting pregnant, they had normal cycles, and then all of a sudden, they like if all of a sudden they start, having issues becoming pregnant and their periods change, I would say, that's really concerning. Like, let's go ahead and assess that. Let's go ahead and assess your thyroid. I think that honestly, the biggest thing that I think anybody can take away is that like the questions that a physician or clinician asks you can be so revealing. Like you may not even think that's a problem, but then you start talking about it and you're like, and they start putting the pieces together. And so like making sure that you have a physician who asks you the right questions, I think is really, really important. Because if you can't ask, nobody's ever going to tell you. Like very few people keep a nice long list of all of their symptoms. And when they started, it's just something that comes out slowly in conversation. And so, yes, if somebody also was found to have subclinical hypothyroidism, that's usually something that needs to be evaluated annually because it can turn into overt hyperthyroidism or overt hypothyroidism. And so you just keep checking to see if it did turn into something.
Yeah. What to your point about, like we don't always know what's remarkable about our own health because we are living in our bodies and just used to it. What are some of the questions that you're asking just because if somebody is not getting the best care that they could possibly get, what information should they be armed with to tell their doctor of, oh, hey, I've been thinking about this. Here's this milieu of things I've been experiencing. Is this an area we can explore? What are some of those questions that you would ask or that people should think about?
Some of those questions would be I would ask about their skin and I would ask about their hair. Because even if somebody says that like if they're having hair loss or they're having dry or very sweaty skin, those are not necessarily an issue with thyroid, but they are an issue with something else too. And so there's usually like a hormonal component going on there, and that can impact pregnancy, that can impact fertility. And so knowing about that, I think is really important. Um, I think knowing your family history is like really valuable. It's something that recently came up for me personally that like I was like I never even like thought to ask my own family member that, but like knowing if your family has any medical problems I think is really important. And so if you can ask your own parent like and parents and siblings are the most important. And so it doesn't have to be that like your grandfather, you have to go sit down and talk to him. But like if you can ask your parents or siblings, have you ever had any problems with your thyroid? Have you ever had any surgeries on your thyroid? Have you ever had any like ever needed to take any medications? I do find that some people, if I say, do you have any problems with this? They say no, but then I see like blood pressure medications in their history, and it's like, oh, you did have a problem. You just don't view it as a problem because it's taken care of. And so asking if people are ever taking medications for that can be really valuable before going into a doctor's appointment or even afterwards. Honestly, a lot of the times I'm telling people like to go review family history, like, hey, could you reach out? Like if I'm super concerned about a diagnosis, I'll say, if you think your mom has that, is there a way for you to talk to her? Or if their parent has passed away, maybe talking to their sibling to gain a little bit more history too. Um, Skin changes are a huge thing. Dry skin, sweaty skin, hot flashes, colds, like cold skin, clammy skin, night sweats are a big thing. Rapid weight gain or weight gain over a long period of time that just you can't really account for, especially if you're like a regularly active human being who like eats a healthy diet. You can't understand why you gained 30 pounds. That's a big thing. Or especially weight loss too. So if you're like weight loss, changes in your face, a lot of times the only time that a physician is meeting you is a single time, and we don't know what you looked like before. And so if you're saying like, hey, my face has changed, like that's a really big, like my eyes feel like they're coming out of my face more than they used to, or my partner has said something, or I feel like I look different. Fat distribution changing on your body, that happens with time. As you get older, your fat distribution is going to change. You should never have like
Oh,
if you
that
have like
hump, are you?
yep, that
Yeah.
hump in the back, like that's
Yeah.
not something I've ever seen on somebody who doesn't, even for people who have higher weights, like you just don't have that.
Yeah.
You never have like a thick pad of fat behind your neck, even if you have a higher BMI that just kind of like curves out. So if you've noticed that kind of coming about, looking to see if somebody would be willing to look into that. Changes in your period too. Like I think a lot of people don't necessarily think that changes in their period or something that's normal, but if you've been a regular person, it's every 28 days for the past 15 years, and now something's changing, that's something to kind of know about too.
Okay. No, that's really helpful. Um, what do you, sort of similar to that, what do you see as the biggest areas of misinformation around thyroid and pregnancy health? And either misinformation that it's like, hey, this is what your patients are bringing to you, that you feel like there's a lack of education, or do you see any type of misinformation on the clinician side of things where, yeah, I'll leave it either one.
Yeah, I think on the clinician side, people like guidelines change. Being a doctor is a busy job. People are trying to juggle, their job and their kids and all their other stuff. And so, new guidelines come out that kind of assimilate research. And we don't always know that they have come out because we're not automatically getting a notification about like this. You have to be pretty vigilant to figure out that a new guideline has been released. And so, sometimes it's just that you're operating on something that you learned 10 years ago and you don't yet know that it's changed. And unless you are either in a big academic facility or like very, very vigilant, you're not necessarily going to know that it's changed. Um, the other thing on the patient side is just a lot of people think it's their thyroid. Like a lot of people do have thyroid problems, and so I think a lot of people think it's their thyroid. And what ends up happening, oops, sorry,
It's okay.
what ends up happening, I think, is that people come in and they want to be tested for something, and um there's a combination between having like a bad relationship with your clinician or feeling like they're not listening to you. And so people come in with this idea, and if they don't feel like they're being listened to, they want the test. They just want the test, and they feel like if they have the test, they're going to have the answer. Um, and there are physicians who will give in to that, and so you start looking for information that you don't necessarily need to have. And so I think it's this mismatch and this like understanding that your clinician needs to be thoughtful and judicious with the testing that they're doing, and that patients need to be flexible in that, but also like your physician needs to listen to you. Because I've had a lot of patients who are like, nobody ever listened to me, and they did have the problem that they thought they had.
Yeah.
And so my feeling at this point is like, it's okay for your patient to be right about what their diagnosis. That's totally fine. Like, that's fine. It's like, I went to med school. That's great. Like, it's okay for them to be right about their diagnosis. You're living in your body. You know what this is. It's my responsibility to take what you're saying and to listen to you, and maybe not do exactly what you're saying, but that doesn't mean I never have to do what you're saying, right? Like, sometimes the right thing is to order the thyroid test. That's exactly what I would want to order. Or sometimes it's that I don't want to do that, but I want to do something else. And so um I think it's just that people end up, for a variety of reasons, having like not trusting relationships with their physicians, where they don't feel like that person's going to listen to them and have their best interest in mind.
Yeah.
Um, in that circumstance, I think that you have to be with somebody that you're comfortable with. Not
Totally.
everybody is the right doctor for everybody. I will be very transparent. People have not thought I was, the best doctor for them, and that's okay. Um, and so if you feel like you're not being listened to, if you're in a position where you can find someone who you feel is going to listen to you, maybe not do everything you say, but listen to you and truly think about what you're saying and like follow up with you and give you the care that you deserve, I would just recommend changing.
Yeah.
Or giving feedback, like saying like, hey, like the most impactful feedback that I've gotten is people saying like, I don't think you're listening to me. Like, and even if I was, like, that is going to change what they tell me, right? And so
Yeah.
if you feel comfortable, say like, I don't feel like you're hearing me right now. Like, is there another way that we can like talk about this? Because that's going to cause that person to stop and slow down and think about it differently. And if they're not receptive to that, you just need another doctor. Because like, if
Yeah.
somebody told me that, I'd be like, we're done. Yeah. And I think encouraging physicians to stay current on guidelines, it's always a problem. It's going to be a problem forever. But I think the biggest thing that any of us can do is like stay up on our guidelines, look for guidelines, look to make sure that nothing has changed,
Yeah.
um, and talk to people who are like experts in that field.
Yeah, and that's a really good point. And just for anybody listening that is not a doctor, or even if you are a doctor, but for non-doctors, the guidelines are public. Most of them are public from the societies. So, and RPLA actually has a number of them linked on our website. You can find them on like the society pages, but I think it's always okay if you're seeing there are different for those of you that don't know, and you can speak to this more, Michaela, like there's different societies for different medical specialties. And so if you're seeing a reproductive endocrinologist, you would expect that they should be aware of guidelines from the American Society of Reproductive Medicine. And it is fully appropriate then to say, hey, here are your society's guidelines. Why are you or are you not, or more likely, why are you not following this? Can you walk me through that? Why do you think that this isn't relevant for me? I think that's like perfectly okay, but I don't know
I think
from your
it's totally.
perspective. Oh,
I mean, I think if somebody told me that, I would be embarrassed, but I would also listen because like, well, that's kind of embarrassing. I didn't know that. Um, but I do think it's a valuable question, like, because sometimes it's that people will not meet the criteria. Sometimes I have a
yeah,
very good reason. I'm like, you know what? Yes, that is the guideline. This is why that doesn't work for you.
yeah,
Um, like, in a perfect example I could think of is like 39-week induction of labor. You can induce anybody electively at 39 weeks except people whose pregnancies are not dated well. So if somebody came in and their pregnancy is dated by a 30-week ultrasound, I can't induce them electively. I don't really know how far along they are. And I think that's a perfectly normal question of like, why can't I be delivered early? It's like, well, this is the reason. And so um, I think if you look up guidelines and you're like, I meet all these criteria, like, why aren't we doing this? That opens up a door for better communication, or at least an explanation about
yeah,
why we're changing things, or it's an opportunity for that physician to review those guidelines better.
yeah. I saw a question that came in, and I think this is an important one. Is hypothyroidism or is thyroid related at all to other kind of hormones related to pregnancy? So specifically, this question is, how is thyroid related to progesterone, luteal phase type of issues and deficiencies? Is it?
There
Yeah. Yeah.
My understanding is that we don't think there is a relationship. However, that doesn't mean that there isn't. Like, that just means we don't have a current link.
Right.
Oftentimes, what happens, especially if someone has one type of autoimmune condition, they will have others. And so, like, a great example is that people who have thyroid abnormalities and thyroid problems are more, or people who have primary ovarian insufficiency are more likely to have thyroid problems. And so we routinely test. There could be a link. I'm just not aware of it. And I don't know that any studies have actually truly tried to look for that link. There could be one. And so I think it is reasonable to say, like, I'm having some hormonal problems. Am I having other hormonal problems? I think it's reasonable to at least take a history and look at the menstrual cycles and see if there is something that pops out. If you think
Mhm.
that there is, like, if you have a difference in your progesterone, there isn't like an established link between those two, but because people have that link, it is worth just like thinking about.
Yeah. No, thank you. Um, we're coming up towards the end. I am seeing some of the questions that come in. So if you've got any others, feel free to type them in and I'll try to ask them. But as we near the end, I guess anything that I maybe should have asked or that thinking about our conversation, you want to make sure that you communicate to people listening as they think about recurrent pregnancy loss and thyroid.
Yeah, I think the biggest thing that I just want to communicate is that, guidelines about management of subclinical hypothyroidism changed back in 2024. And so people, I think that's really jarring, right? Like that's really hard when you were like, if you've had a loss that you're like, this thing worked, right? Like I want to do this thing again. And so that's a really difficult situation to be in. As a physician taking care of somebody, I would have to listen to them and just like think about what I wanted to do. Like, having losses, as everybody here knows, is really challenging. And I
Yeah.
don't know that I would tell somebody that I wasn't going to prescribe a benign medication to them that, that they, if they really believe that that was associated with their positive pregnancy outcome, I don't know that I would take that away. Like, I think that that would just be really hard for someone. And they would probably be really hurt if they had another loss that may not be associated with that at all. But they really would feel like I didn't give them the thing that worked again. A lot of this came up with like progesterone and preterm labor, and when it no longer became like on label to give
Oh,
progesterone.
right. Yeah.
A lot of people were like really freaked out, and I think that's like a reasonable way to feel that like you took it, it worked, and nothing had worked before, but this took it. And so I'd probably prescribe that again. But in the face of current guidelines, if you're having a new evaluation, I would just, not think that the 2.5, like you don't have thyroid. If you have a normal thyroid hormone and a normal T3 or T4, mostly T4, that it's okay. That like it's not your thyroid. Unfortunately, a lot of people, most people who have recurrent pregnancy loss don't have an established diagnosis. And so um just accepting that it's not your thyroid, that it could be your thyroid later, but at that point it's not necessarily your thyroid, and that we need to look for other options. Unfortunately, it would be so easy if it were thyroid. It would be great if it were thyroid. And
Yeah.
I love when it's somebody's thyroid because it's just such an easy thing to treat.
Yeah. Yeah. So if you're, yes, it's like one of those where I can feel that from the patient perspective where it's like, well, if it's benign, just give it to me anyway. But what the new evidence is what you're saying is like, if your thyroid is not, it is above 2.5, but it's still within the normal reference range and your T4 is normal, probably this issue is caused by something else, which warrants further explanation and investigation, but is probably not your thyroid. Yeah. Okay. Yeah,
It's
that's
really hard. it's
yeah, it
it's
is. It's
really
so
tough.
hard. It's so hard. You're like, yes, for everybody that has lived through this that's listening, I'm like feeling this acutely in my body. So I
Yeah.
get it. If you're like listening to this and you're like, no, just give me the pill.
Yes.
Yeah.
And it's not fun to tell someone that at all. I personally like feel like I'm not being a judicious clinician if I give someone a medication that's not going to help them at all. I'm like, here, just take this, it'll be fine, and then it's not, and I feel bad. But I don't know, if somebody had a prior losses and was coming to me and they're like, I took levothyroxine, I want it again, I probably would just give it to them.
Yeah. Is that how frequently in your practice have you seen, and this was the question that came in, like how frequently do you see a case of recurrent pregnancy loss where it is thyroid related? That is the like thing that was identified and then it fixes the problem for future pregnancies.
Yeah, I don't know that I've ever seen that. And
Wow.
here's what I'll say. A lot of people who have recurrent pregnancy loss don't have any testing, right? Like we
Yeah.
don't. Like a lot of people, for a variety of reasons, like never have testing. There are very, very low rates of diagnostic evaluation for patients with
Yeah.
recurrent pregnancy loss. That's actually like one of my interests is like, why are people not getting tested? Because
Amen.
we don't actually know like what the evidence about what the actual prevalence of this disease is not well established. It's
Yeah.
probably much higher than 5%. In my own patient population, it is 10%. And so, like, it is much higher than we think it is. And so that could mean that it's like a variety of different things that are going on. Um, we do know that, like, the literature does show for people who specifically are looking at, um, thyroids. They're like looking at people who had recurrent pregnancy loss, were diagnosed with a thyroid condition, and then were treated. Like that does work. Like that does fix their problem. There's like a massively increased likelihood that you'll carry a pregnancy and not have another loss. And so if you're thinking like, do I need this medication? I would say like that's something I'd put my money on. Like if I can diagnose you with a thyroid condition, um, and I can treat that thyroid condition, that is going to help, especially if it's hypothyroidism. Like there is a lot of data that suggests that that is going to be profoundly helpful. The other thing is that, like, even if you are able to conceive without taking the levothyroxine, that's somebody who I think is probably really going to need levothyroxine to have a good outcome for their pregnancy. Everybody's goal is not just to be pregnant and have a baby, it's to have a healthy baby. And so like I would say like I would really be concerned about what we were potentially doing to the cognitive health of the baby if we weren't taking the levothyroxine.
Awesome. Thank you so much. This was I learned, and this was educational for me, and also it's just always really fun to talk to you. So thank you so much for continuing to be passionate about educating patients. Thank you everybody that watched and submitted questions and kind of stuck with us through this. This will stay posted on Instagram, and eventually I will get all of these things transitioned over to YouTube. But in the meantime, please feel free to, send Recurrent Pregnancy Loss Association a DM, send Dr. Wyszewianski a DM. She can answer more questions, or I can forward them to her. But, please you be an empowered patient. I think so many important things said of making sure that you trust the person that's giving you care. It is okay to ask questions. And just like any relationship, it goes two ways. So yes. Thanks, Taylor. Yeah.
I
Any
would
closing
certainly
questions
love
from you? Yeah.
Yeah, I would love to answer questions. So if people want to reach out to me, I'm totally okay with that. Um, I will definitely look into, I think that that's such an important question is like looking at like sperm counts and like, I
Yeah.
just don't know. And so I'm certainly happy to look into it and I'll send Megan a response and she can help disseminate that information. I think that's going to be important for me to know because legitimately, like because I do not take care of male patients, I just never thought about it.
Yeah.
And so I'm going to look into it and I'll get back to you.
Yeah, and you'll give yourself a year once you're in that RE fellowship. This will be yeah,
I'll probably think about
then
it all
you'll
the time.
be up to your eyeballs in sperm things.
It's going to be great.
Yeah. All right. Everybody have a good rest of your day, evening, wherever you are. And we have other topics also that we're planning on diving into. So if you've got a topic that you'd like us to discuss, let us know because we'll continue to do these conversations in this series. All right. Bye.
Bye. Have a good day.